waves, normal, upright. All right, QRS, looks good. All right, so yeah, so do me a favor and write normal sinus rhythm on that one. All right.
So my heart rate is 150, so it will be tachy.
Okay, it's the tachycardia. But what's the one thing that really jumps out at you about that particular one? Do you see any P waves? Or even better, do you determine a normal P wave before each and every beat? Okay. We'll look at the regularity. Would you call that regular or irregular? Yeah, definitely. Can you predict the irregularity to it, where it's going to be irregular when it's?
Not really.
All right. So that one, big thing, no P waves, irregularly irregular, and it's a narrow complex. That tells us what? Atrial fib. Yeah, so it's AFib. That one just happens to be one of the fast AFibs. Because remember, it can be a normal rate. It can even be a slow rate. But it oftentimes, when patients present with it, it's because they're having a problem because of the fact that it's fast. Yep, absolutely. Yeah, that one is sinus tach. Everything's normal, it's just fast. All right, so write that one down. Okay, what do we have?
Heart rate's 47.
All right, so right off the bat, we know it's slow.
Right. So,
Do we see P waves?
yeah.
Are P waves all normal and upright?
Mm-hmm.
When we look at that PR interval, it looks good. It's not delayed, and it stays the same. Okay. There's a QRS after every P wave, all of that good stuff. So we know that it originates where? Because we have a P wave.
SA9.
All right, so what kind of rhythm will that make it?
The sinus.
Okay, so it's a sinus brady, right?
Yes.
All right. And forget, don't pay attention to that part. That was not, that was left over from one of the previous rhythms.
The heart rate is 127 active.
Okay.
So that's anyway.
All right.
So I would say sinus.
Absolutely. The sinus tach. All right. What we got?
Heart rate 72, so it's normal. And then
And they're all the same. So yeah, that one will be a normal sinus rhythm. Oh, you're fine. You're fine. All right. What you got? This is wait. No.
Like that.
This one, I'm sorry. I told you to go on that one. That one is actually an atrial flow. It's a 2-to-1 conduction, and what happens is that QRS is jumping in on the second P wave there. So where we would normally see that, and that's the thing about a 2-to-1 is that it's kind of hard to realize it's atrial flutter because a lot of times what we think is a T wave is actually that first P wave. So yeah, and that's what that went through. Because I remember, like, wait a minute, the SVT did not show that. So yeah, that would be atrial flutter. All right. And this one actually kind of throws in.
Well, yeah, because
Yeah. And but But this is actually what, and your book doesn't refer to it, but this is what we would consider a PSVT, a paroxysmal supraventricular tachycardia, meaning we're watching it develop, that we're watching it come and go. If they show up and we never see a normal sinus rhythm in there anywhere, we consider it SVT. But when we watch it come and go like that, we refer to it as a paroxysmal. So it's, but yeah, it's SVT. All right, just write that on there. Because what I'm gonna do is let everybody pass these around the share. Okay. All right. Yep, that would be a sinus break. All right. First step. Do you see a P wave? No, it's not there. QRS is normal, it's narrow. But when we look at the regularity of it, would you call it regular or irregular? Yeah, it's very irregular, right? Can you predict any pattern to the irregularity? Is there any pattern whatsoever? Can you determine when it's going to be regular again? No. Okay. So that would be, what's the one? It doesn't have a P wave. QRS is going to be narrow like that. But it's irregularly irregular. Yeah, atrial fibrillation. So whatever it was, right in there.
Yes, and I very rarely ever seen a 2-to-1.
So the SVT doesn't have to be very much.
Yes, it can have.
She was asking what.
No, you said that.
It's
Because
usually
we want.
Flutter is regularly regular, and it'll have a definitive sawtooth pattern, right? That's a 2-to-1 flutter on that strip right there, if y'all want to
Yeah,
look at it. Although I've very rarely ever seen a 2-to-1 that runs that long.
yeah, it's
Sam, are you like boarding the strips over there, baby doll?
Yeah.
all right. Just make sure that you write
Here,
on
I'll
it
trade
what
you
we
a green
agreed
for,
on so we can pass it around.
Look at that one, Kelly. It's ours not.
Oh, okay, all right. Introduction itself. Generally, you're not going to see that much for
Well, I was gonna finish.
but for the most part, you're going to see it
I
early
was
on.
gonna finish.
This is going to be
No, I thought you all said something.
the part that you see, as far as central.
So AFib never has T-wave?
Yeah, it's usually like either a 3 liter or 4 liter.
This is a flutter.
A flutter.
All right.
So that one into has no T-wave.
All right, so y'all pass that around and look at those. And we're gonna go ahead and start talking about the AV block.
Regular.
The atrioventricular blocks can be somewhat confusing, okay? And because there are different types of them, we have first, second, and third degree heart blocks, or AV blocks. And when we're looking at them, basically all we're seeing, and remember, we're not talking about a physical blockage within the heart, okay? We're talking about a blockage of the flow of electricity, okay? So we're not talking, that's one of the things I see where students will get confused with this to begin with, because they're thinking of a physical block, like what would happen with someone who has an occluded coronary artery that's having an acute myocardial infarction, heart attack, right? But that's not what we're talking about here. We're talking about a blockage within the flow of electricity. And it occurs in that conduction pathway between the SA node and through the AV node. So remember, like I was telling you, where generally that impulse is generated in the SA node, it goes to the AV node, and the AV node kind of catches it and holds it for just a second, just a fraction of a second, and then retransmits it. Well, for whatever reason, there's a blockage between the SA node and the AV node, okay? And sometimes, depending on the level of the blockage, whether we're looking at a first, second, third degree, the SA node may still be communicating with the ventricles. It may still be sending an impulse down to the ventricles. Sometimes it's not, especially with third degree, which is we call third degree complete heart block, because of this reason right here. With first and second degree, that conduction of the electrical impulse is only delayed, okay? It's only delayed, whereas with third degree or complete heart block, that atrial impulse never actually makes it to the ventricles. So you have the atria that's kind of doing their own thing, and the ventricles that are doing their own thing. And with that one, generally, rate's going to be 30 to 40 beats per minute. They're going to be really slow. These patients are often going to be symptomatic. And basically what we're looking at there is they're going to need a pacemaker for especially second and third degree heart blocks. A lot of people walk around with first degree heart blocks all the time, no big deal. And if you notice, it doesn't go into that whole lot, okay? No. But we do have, like I said, different types, first, second, and third degree. And there are actually two different types of second degree. All right. So now we're going to look at some ventricular dysrhythmias. So these are dysrhythmias that occur or they originate within the ventricles. Most common one is a premature ventricular contraction, or PVC. And with PVCs, most of the time they're not dangerous. Most people have them. And basically what happens is it's kind of like that PAC that we talked about. It's a complex, it's an ectopic beat that occurs just because some spot, some foci in the ventricle, all of a sudden generates an electrical impulse, and it generates it early. So it basically, you have this ectopic foci in the ventricles that generate this electrical impulse early before the SA node is actually able to generate its electrical impulse. So usually what we're going to see here, they're not going to have a P wave, and it's going to have a wide, bizarre looking rhythm, or a wide, bizarre looking complex. Remember, we're talking about a single complex here. We're not talking about, the entire rhythm. So I'll take a normal sinus rhythm, and this one's not as wide and bizarre looking as I would like. But usually PVCs are pretty benign. generally, like I said, PVCs are usually pretty benign unless someone's having a lot of them. Because they generally are not complexes that are going to generate a good, strong stroke volume. No. So, here, I'll tell you what, I'll start this one at the front, pass it around. So if we look there, first thing we always do is we look to see what the underlying rhythm is. So if you look at that, you'll tell that the complexes that you can see that are normal are all a normal sinus rhythm. So it would be a sinus rhythm with frequent PVCs on that one. That patient may actually be somewhat symptomatic because they're pretty regular on that one. Usually, so a lot of times what we'll see with these, like I said, these wide bizarre complexes, sometimes they may experience with pallor or nervousness, sweating, faintness. They may feel a fluttering sensation in the chest, kind of like they do with SVT.
Yeah. When patients have like palpitations, is that just the normal heartbeat, or do they feel this a lot? Like is that kind of like?
Generally, when patients tell me they feel a fluttering in their chest, I'm thinking more of something like atrial fib that's really fast, or SVT, but they can experience it with this as well. And especially if they're real regular. If they're having a lot of them, they can feel it. And like I said, if someone's having occasional PVCs, it's generally harmless. Can be related to anxiety, stress, fatigue, alcohol withdrawal, tobacco use. So it kind of comes back to that nicotine and caffeine use. All right. So here's some rules that we have for PVCs that may lead to or indicate that we may experience a lethal dysrhythmia. Okay? They're having 6 or more PVCs per minute. So if you look at the one that I just passed around, notice that's way beyond the 6 per minute. All right. And then we have what's known as runs of bigyminy or ventricular bigyminy, and it's where every other beat is a PVC. And remember, a lot of times these PVCs are non-perfusing beats. So even if it's showing a rate of 80 and every other beat is a PVC, then really, as far as actual perfusing beats, of the heart, it's down around 40. So, all right, you have 2 PVCs in a row. That's called a coupling. That could be a sign that, the patient may be experiencing some ischemia, lack of blood flow to the heart muscle itself. So we're thinking there's the possibility they may go into some type of lethal dysrhythmia. A run of PVCs, where we're talking about having 3 or more PVCs in a row. Multifocal PVCs. And when we're talking about multifocal PVCs, we're talking about PVCs that originate from more than one spot within the ventricles. So they look different. They're not shaped the same. So if you look at this strip that I passed around, all of those PVCs look exactly the same. When we're looking at multifocal PVCs, they're going to be shaped different. They may go in different directions. One of them, the actual QRS part of it may go down, may have a negative deflection. The other one may have a positive deflection, or they may just have a different shape in general. Multifocal PVCs are always considered to be more dangerous than unifocal PVCs, just because you have more than one spot within the ventricle that is creating that ectopic beat. And then this last one is really, really dangerous. That's when you have a PVC where the R wave actually falls on the T wave of the preceding complex. Okay? And so what we're talking about here is you have a normal complex where you have a you have your P wave, it's followed by QRS, and then as your T wave is getting ready to form, a PVC lands on. A PVC originates right there. It's called R on T phenomenon. And it can actually cause patients to go into lethal dysrhythmias like VTAC or VFib, even systole. All right. When we're dealing with dangerous PVCs and these situations where the patient's having a lot of them, or they're having bigeminy, they're having couplets on a regular basis, or we're looking at those lots of or frequent multifocal PVCs, and we begin to treat it, through chemical cardioversion. So with medications, the drug of choice there is lidocaine. And with lidocaine, the way it's administered is you do a bolus or a loading dose of lidocaine that is then followed by a lidocaine drip. All right, VTAC. This one is kind of unique in that with VTAC, it can be a perfusing rhythm or a non-perfusing rhythm. And what I mean by that is they may have a pulse with this, or they may not have a pulse with this. Okay? But basically what happens with VTAC is we have a single spot or single focus in the ventricles that initiates the electrical impulse, and it becomes a repetitive pattern. So rather than having a single PVC, your entire rhythm is basically PVCs. They're ventricular complexes. So they have a wide, bizarre look to them, but they are regular, if you notice. And I'll go ahead and tell you that, and it has the same, because it has that same repetitive pattern where that spot in the ventricles keeps firing. It is very regular. Can be very fast, and obviously it kind of goes back to like the SVT and the atrial fib with RVR. When they get really, really fast, it reduces cardiac output. And like I said, with VTAC, this is one of those that patients may actually not have a pulse with, or they may still have a pulse with them. So with this, because it does reduce cardiac output so drastically, they very well may lose consciousness, and they may go into a VTAC where they initially have a pulse, and then it goes away. And sometimes it will, patients will experience what we refer to as a run of VTAC, where we will have, basically, they may have 5, 6, 10 ventricular beats, and then they go back to a normal sinus rhythm or whatever their underlying rhythm was. Kind of like what we were looking at with the SVT strip that I passed around. So the big thing here is it's very regular, it's fast. There are no P waves, right? Because it all originates in the ventricles. The SA node is doing absolutely nothing here. The bad thing is that if it is persistent, it can lead to VFib, which is even worse because that is definitely a non-perfusing rhythm. All right. So with VFib, this is basically the rhythm of a dying heart. This is where the ventricles, because it's originating within the ventricles, you're having multiple spots within the ventricles that are firing at the same time. And because of these multiple spots firing at the same time, there's no organized activity whatsoever. So basically what we're seeing is the ventricles are just sitting there quivering. Okay, they're just quivering. That's all they're doing. They're not contracting effectively. There is no cardiac output. The only treatment that we have for this is to begin CPR and to defibrillate these patients very quickly. So this is definitely a lethal rhythm. This is one of those that when you were going through CPR and you talked about making sure we defibrillated the patient as quickly as possible, as soon as an AED or defibrillator was available. This is one of the rhythms that we were talking about. Because this one is going to proceed to a systole or flatline fairly quickly if it's not being treated. And plus, like I said, because there's no cardiac output with this, there's no effective contractions of the heart, nothing is being perfused, right? So this is why we're having to do CPR, to maintain a blood pressure so we can perfuse the brain and those other vital organs. All right. The client is experiencing premature ventricular contractions and reports a fluttering sensation in the chest. The nurse explains the causes of the client's symptoms as A, the ventricles are beating very fast, 150 to 250 beats per minute. The ventricular contraction occurs early and independently. C, it is a rhythm of a dying heart. Or D, single atrial impulses outside the SA node causing the atria to contract at an exceedingly rapid rate. Which one is consistent with PVCs? B. Remember, it's just PVCs are just early contractions that occur independently of the regular cardiac cycle. All right. It's really, really great to have a 12 lead available, okay? Oftentimes we only have the monitor strips like what I was handing you, or that's what we have initially. So a lot of times we can look at our rhythm strips, make a determination, of what we think it is. But the good thing about if you have a 12 lead that is available, it will actually interpret the rhythm for you to kind of confirm. But it's like any other piece of equipment, it can be wrong. I've seen them make mistakes before. And I have a question. Depending on the text that you're using, some will use the term ECG, some will use the term EKG. What's the difference? Nothing. Why? What? Why? Where was it developed? Germany. And in German they spelled electrocardiogram with a K. So when they first came out, they were referred to as EKGs for years and years and years and years. And then somebody said, well, we're going to make it different here, so we're going to start calling them ECGs. So you'll have people like me and Miss Cheryl, the old people, that still refer to them as EKGs. But a lot of textbooks don't use that terminology anymore. All right. So, like I said, it's great when we have these tools available. And it's because they help us confirm what we already suspect is going on. And like I was saying earlier, talking about, electrophysiology in general, where we're looking, interpreting, the structures that are actually causing an issue in these dysrhythmias. And basically, when they do an electrophysiology study, they're actually stimulating the structures, okay? The inside of that conduction pathway in order to see exactly what dysrhythmia is being produced and where is it originating from. So it's really, really neat. And basically, it's, there's several different ways that they can treat that, but it can help prevent having these dysrhythmic episodes. For example, people that have SVT, if it's one of those issues where they have it on a regular basis and it's not able to be controlled with medications, then they will have this done, and basically they go in, they stimulate the portion that's causing SVT. They're looking for what we refer to as that re-entry circuit, and then they'll do an ablation where they basically burn out that ectopic tissue, and it oftentimes gets rid of that chronic problem. So a lot of times, like I said, this is something that they do with patients that have had a chronic problem of something like SVT. All right. Some drug therapies that we use, oral and IV antidysrhythmic drugs. We have procainamide or Pronestal, isoproterenol or Isoprel, amiodarone. This is a good one. This is actually one that, depending on if you're looking at AHA's version, American Heart Association's versions for things like ACLS, highly, highly recommended. And then class 4, verapamil, Kalan. That's another one that has a lot of side effects. But it's one of those things, I would be familiar with these medications. And then there are times when our patients are unstable to the point that we need to do electrical cardioversion. And remember that when it comes to cardioversion, it's not like the defibrillation we do with a patient that's in cardiac arrest, okay? It's similar, but it's not the same thing. Because what happens with cardioversion, matter of fact, let me back off real quick. Let's say we were going to cardiovert this SVT here. This is what's really neat about this, is the way it works. But when we use synchronized cardioversion, we're actually shocking the heart at a very specific point in time during the cardiac cycle. You notice on the strip that I'm passing around now that it has all of the QRSs marked. It's actually in what we refer to as sync mode. And so if you look at the top of it, you'll see it has an S at the very top above every QRS. It's actually, and what's neat, when we get ready to deliver the shot and we push the shot button, it's not like regular defibrillation, where defibrillation is immediate, just boom. With synchronized cardioversion, it will wait just a second and then deliver that shock at a very specific point in time in the cardiac cycle. But with electrical cardioversion, we're using less energy. Doesn't take as much energy as regular defibrillation does. So defibrillation is not time. This one, so we're looking with defibrillation. We're actually shocking rhythms like V-fib and pulseless V-tach. If they have a rhythm that has a pulse, whether it's SVT or atrial fib with RVR or V-tach with a pulse, we have to use synchronized cardioversion. But unfortunately, like I said, it depolarizes the entire heart. Yes, ma'am.
Is that like what they use sometime in the ambulances when a person isn't unconscious, but
Right.
they know that they're having a lot of heart trouble? They use
Well,
that kind
and generally, it's to control the rate. It's because, like I said, with the SVTs or the AFibs with the RVRs, they've got to the point that now they're unstable, their blood pressure has bottomed out or whatever, so we need to cardiovert them right now. Because preferably, we want to do it medically. We want to do chemical cardioversion. That's generally safer. When we use electrical cardioversion, we always run the chance, because of the fact that we're depolarizing that entire myocardium, we're always running the chance that we're going to stop the heart and it's not going to start back normal. It's, when your computer locks up, won't do anything, it completely freezes up, you push every button, you do Control Alternate Delete, you hit Escape, you hit the power button, it does absolutely nothing. So you walk over there and you unplug it from the wall, right? We all know you're not supposed to do that, but we do it, right? That's what we're doing here. This is that last chance. We're delivering that shock, hoping that it's going to restart the heart normally. Yes, ma'am.
So the elective electrical cardioversion, that is, you said, synchronized?
Yes. Yeah, if it's elective, then yes, it's, and it's neat. There's different ways to do that, but, for the most part in the field, or even for the most part in the hospital setting most of the time, we're using the same type of pads that you used with the AEDs. I think even your textbook shows the paddles. Hardly anybody uses paddles anymore. They've gotten completely away from that. All right, so let's kind of talk about what we were just talking about. Defibrillation, we're looking at V-fib or pulseless V-tach. So this is a patient that does not have a pulse, and they have a lethal ventricular dysrhythmia. And it's not in the algorithm for the system. But there are different types of, like I was just saying, there are different types of machines that can be used for defibrillation. Obviously, an AED, I'm sure you guys talked about those and played with those when you did the CPR part. So those are pretty much idiot-proof, right? They tell you exactly what to do. You just have to know how to turn it on. So it's one of those things, you know where it is in your building. And then we have a lot of patients that will have AICDs, which are automatic implanted cardioverter defibrillators. So this is that patient that has had problems in the past, usually. And so now, just like they would implant a pacemaker, they implant this. And they have these, just because, like I said, they have had these recurrent life-threatening tachydysrhythmias, such as V-tach, that keeps coming and going. So what they do is they implant this, and it's constantly monitoring your heart. And when they go into this V-tach or whatever the tachydysrhythmia happens to be, it delivers a shock. And because it's just like a pacemaker, the electrodes are embedded directly into the heart muscle itself. So it's delivering very low voltage. Now they can feel it, it hurts. And sometimes they don't even realize that they're having one of these tachydysrhythmias. Sometimes they can feel it, they know that it's fixing to happen, but I've also seen people where implant, their internal defibrillator, just started firing. And you end up having to have it reset, removed, whatever. Yeah, it's rare, but they do malfunction from time to time.
Is
Yes,
there any
ma'am.
way to tell the difference, like when you're like seeing a rhythm between like AICD, pacing spike, and just the normal pacemaking, like when it maybe doesn't pace all the
Oh,
time?
yeah, yeah. Now, like, you mean as far as determining the difference between a paced rhythm?
Well, you know, like some people are paced and it doesn't pace like the whole time. Like, is there a way to tell
And
between
no,
AICD or?
Yes, there is, by looking at rhythm. And there are different types of pacemakers. And that's one of the things that we're talking about. You have like demand pacemakers, you have, and then you have a fixed rate pacemaker. But basically, when we talk about pacemakers, we're talking about replacing the SA node, right? Because the SA node is the normal pacemaker of the heart. So what we're doing is these patients, for whatever reason, maybe they experience third degree heart block or complete heart block, and their heart rate now, was in the 40s or so. So now they've decided that we're going to, because of this really, really slow heart rate, we're going to put in a pacemaker to get their heart rate back to and maintain it at a normal rhythm or a normal rate. And it's implanted just like the internal defibrillators, like the automatic internal. Usually going to be sitting right under the collarbone. And like you were saying, there are demand pacers and there are fixed rate pacers. Demand pacers only work, they're only delivering that shock, or they're only pacing the heart when their heart rate falls. Does that make sense? So once their heart rate, for example, it's set at 72 beats per minute. If their heart rate drops to 65, then it's going to start pacing them. All right? And now to answer your question, okay? If it's not pacing them, you won't see it on the monitor. Okay? You will only see it if it is pacing them. All right, and then they have fixed rate pacemakers. And basically, they're set up to where they produce, an electrical stimulus, or, they are actually pacing the heart somewhere at 72 to 80 beats per minute, regardless of what the client's natural heart rhythm is doing. Okay? So it's pacing all the time. Pacemakers can be permanent or temporary. For example, when patients have, when they have bypass surgery done, they have a temporary pacemaker that is inserted. The wires still come out, and they're strapped to their, and it's actually strapped to the outside of their chest. And for a certain period of time after their surgery, they still have that external pacemaker. And then after X number of hours, they remove it. So they can be permanent or they can be temporary. Like I said, generally the only time you're going to see a temporary pacemaker would be in like a surgical intensive care unit, something like that, or just post-surgery. All right. We talked about ablation earlier, and this is one of those where people that have those tachydysrhythmias, such as SVT, can go have the electrophysiology study performed, and they find the spot that is causing, that ectopic focus is causing the abnormal dysrhythmia, and they use a heated catheter tip that, like I was saying earlier, it destroys that tissue where that ectopic beat is coming, where that ectopic rhythm is coming from. And when they do this, some complications that they can experience, obviously bleeding, because we're going in, you know, through a vein here, right? And because if you notice there that here they're talking about pacemaker lead, it enters the external jugular vein. But they go in, so because we're having to go in through the vessels there, obviously bleeding can be an issue. And like I said, they put that pacemaker lead, it's tunneled down kind of subcutaneously between the pacemaker and the external jugular vein. And then the pacemaker generator is placed beneath the skin in the pectoral region. So that's one of those things where if we have to defibrillate a patient and we see that they have some type of implant, because guess what, in the field, or you know, a lot of times you may not know whether it's going to be a defibrillator, is it an internal defibrillator, or is it a pacemaker? They look the same from the outside. So make sure you don't place your pads over it if we're having to defibrillate them. And what is pericardial tamponade?
Compression of the heart.
All right. You know the heart sits inside that pericardial sac. You know, what happens is sometimes the heart can actually bleed if it's been damaged, and blood leaks outside of the heart but into that pericardial sac, and basically it affects the heart's ability to fill with blood because it can't expand. And it is, like you said, it puts pressure on the heart. All right. So when we're dealing with clients that have dysrhythmias, we want to look at certain things as far as nursing diagnosis. Decreased cardiac output. Want to make sure they maintain physical and emotional rest, because the more they move around, the less they're actually perfusing, right? We don't want them to get upset because that's going to increase heart rate, increase stress. Supplemental oxygen, and that's going to depend on if they're having any level of hypoxia, right? Generally, if they're having mild hypoxia, we're looking at something like a nasal cannula. If we're dealing with patients that have, you know, moderate to severe hypoxia, we may be using anything from a simple face mask to a Venturi mask to non-rebreather, just kind of depending on what we need to do there. A lot of times, and I actually had somebody ask me this question yesterday, and completely different, not necessarily dealing with a dysrhythmia issue, but it had to do with a blood pressure medication. They stopped me and asked me, what would cause someone that takes blood pressure medicine to have consistently high blood pressure? And my very first question was, how long have they been on the blood pressure medicine? They said, about 4 weeks. I said, okay. First of all, some blood pressure medicines take a while to start working. Okay. Now, that being said, the same blood pressure medicine doesn't work for everybody. Okay. Some people. So that's one of those things that when we're starting medications on our patients, have to understand that sometimes it just doesn't work the way it's intended. And sometimes it takes a while for these medications to work. A lot of times they will have, these medications will have their own side effects. Like for example, like I was telling you guys about the adenosine, where, you know, we always warn the patients, it's going to make you feel really, really flush. You know, so be familiar with the side effects of the medications that you're going to administer. You know, be familiar with the dosage, and you know how, you know, the actual administration technique for giving the medication. That's really important. Like I said, with the adenosine is a prime example because of the fact that it has to be given so quickly. It has to be given push, you know, because of the fact that the half-life is so really, really short. So, you know, when it comes to the techniques for certain medications, be familiar with those. You know when it's appropriate to withhold medications. There are times when, you know, a certain medication is not warranted because maybe of a side effect or something like that the patient has. And as far as giving patients information, you know, about things or precautions when they have that automatic internal cardiac defibrillator or pacemaker, you know, they will need to be familiar with those. All right, which of the following statements would require additional instruction to the client and their families regarding permanent pacemakers? Obtain and wear a medical alert bracelet, palpate the pulse and count the full rate, or count the rate for a full minute daily or when feeling ill. Request hand scanning during airport security checks. Or resume normal activities, including lifting after pacemaker insertion to avoid arm swelling. What?
D.
C?
D.
D? Oh, okay. Resume normal activities, including lifting after pacemaker insertion to avoid arm swelling. Yeah, so that's one of those things where if you don't resume those normal activities, don't start moving that around, it will start to swell. And all right. Any questions about anything?
I had a question
All right.
regarding lidocaine and VTAC.
Yeah.
Chemical action of lidocaine on the heart, because I know we can use it as local anesthetic.
Oh yeah,
and,
yeah. It's
you know,
a different.
How does it work when you do it IV?
It is actually considered as a ventricular antidysrhythmic medication. And let me turn